Thank you for having me today. It's an honor to be here and to present our publication. I'm with a program called Roots to Thrive, which is a ketamine-assisted therapy within a resiliency program. There we go. So I am a medical doctor in British Columbia, Canada. I'm an adjunct professor at the Vancouver Island University and a clinical instructor at UBC. I wear a lot of other hats, but for this, that's what's most relevant. I have no commercial conflicts related to ketamine in this program. I am a paid medical lead in the nonprofit program, Roots to Thrive, which I'm talking about today. And in Canada, we like to give a land acknowledgement on where we are working and playing. So for me, I work and live on the Klahoose First Nations land in British Columbia, in Canada. So here is our publication. We published earlier this year, a cohort-based case report, the impact of ketamine-assisted therapy embedded in the community of practice framework for healthcare providers with PTSD and depression. So I'm going to go right to the meat of it, right at the beginning, and then work there again. So in our program, a 12-week program, cohorts 1 to 4, which we published on, these are our results, which we knew were there and we were happy, and so we knew we needed to publish on it. 91% had a clinically significant reduction in generalized anxiety. 79% of the participants in our program had a clinically significant reduction in their depression. 86% of those who screened positive for PTSD at the beginning of the program screened negative at the end of the 12 weeks. And 92% had significant life work functionality improvement. So the program itself was developed, the first part of the program, the Roots to Thrive, was developed by Dr. Shannon, a nurse researcher at Vancouver Island University. And the Roots to Thrive program is a resiliency program that she developed over her academic career and early, based on her recovery from her own traumas. And she was offering it as a program for resiliency for nurses. And it was becoming increasingly popular. And we crossed paths at a point and knew that we could help the program be even stronger by adding in the ketamine-assisted therapy portion of it, of which I was doing in my chronic pain management, or my chronic pain practice. So we married the two programs together, and we created a three-prong approach with the program. So the first part of it, the Roots to Thrive ketamine-assisted therapy, is a service delivery first and foremost. And our target population out of the gate was healthcare providers with burnout related to job burnout, PTSD, depression, anxiety, and frontline healthcare workers and first responders. The other part of it is we knew that we were going to need to research and publish on it to get it funded. It's not fully funded in British Columbia, where we are. And so it started out as a quality improvement project, where we first published on the project and then the quality improvements. And we are constantly in quality improvement with the program. It's not a static program. And the third arm of that is education. And so we take on nursing students, medical students, residents, and we also mentor and apprentice our colleagues that want to either replicate the program we're doing or join our team. And so we are committed to always having these three prongs related to the Roots to Thrive ketamine-assisted and other psychedelic assisted therapies that the program does. So the resiliency program is actually quite simple and straightforward. It's a 12-week resiliency program. It's 2 hours a week online. The larger group, which now exceeds over 100 participants in each cohort, they come together online on Zoom with the whole team, with a large, what we call a coming to know, which is a teaching around resiliency, around whatever we need to get them to start moving into their healing process. And we develop these large group teachings that last about 20 to 40 minutes at the beginning of each session, based on what we know is going on in the team or in the participants that have been enrolled. So their traumas, their PTSD, their depression scores, their anxiety scores, their resiliency scores. And with team meetings, we figure out what is the basic foundations that we have to help build first and foremost, and then move them through the program. On the same day, after the 20 to 40 minutes coming to know, which also has some somatic therapies, some grounded exercises, some meditations, then they move into their smaller groups that are facilitated with 2 facilitators that are therapists, and small groups of 7 to 8 participants usually. And within those small groups, they again get embodied, they do some grounding exercises, they connect, they answer some very focused questions that help them get out a story, get them moving into their healing process, and the facilitators facilitate that. And then within the bigger 12-week program, they have 3 ketamine-assisted therapy sessions at weeks 4, 5, and 7. Those are on weekends. And at that time, the whole group that they have been meeting with online come together, and they have a group ketamine journey or session together with the facilitators and support from the larger team. Our team is quite large and it is growing. We have the privilege of having people wanting to join our team from all over. And so it's a flat hierarchy. I am not at the top of this at all. As a medical doctor, we all work on a flat hierarchy, recognizing that all pieces, all therapists, everybody is important to the team and everyone brings a very important piece of the knowledge and their therapy and their skill sets. The medical doctors include my pain specialties, sleep specialties, addiction, which if you're having the same problems we have a huge substance use issue here in Canada, and psychiatry, and we have a number of other specialties that may be joining us in the near future. We have Indigenous elders and Indigenous members of our team. We have 3 MDs that are Indigenous joining our team, and it's what they really bring, not only their knowledge and their traditional knowledges, but the ceremony, bringing back in the ceremonial aspects of community. And so we really think of this as interweaving Western style with our traditional styles of being in community. And so the Indigenous elders are quite important. And actually, they usually open the beginning of our weekly meetings to really ground everyone. We have many nurses who hold 2 hats, nurses and nurse therapists. They have a lot of skills, a lot of ICU nurses, ER nurses have joined our team. We have energy workers, functional medicine specialists, clinical therapists, somatic therapists, spiritual counselors, and we actually have some exercise specialists as well, which I didn't have listed here. The whole team is trauma informed. We as a team have a team training day in between each cohort where we work on our trauma training. We make sure that we're bringing our level and our skills up as a whole team on trauma, the best trauma-informed practice. We do cultural sensitivity training. We serve a wide population of people from a lot of different cultural backgrounds, and we really, really want to lean in to being very sensitive to this. If we're going to be helping people in trauma, then we don't want to be causing trauma. The team is in ongoing learning all the time. As I said earlier, there's no hierarchy, and the team also practices what we preach. So when we offer the grounding exercises at the beginning of the program or at the beginning of each session, we do them as well. And on the ketamine session days, the team arrives an hour early so that we can take some time to ground, relax, show up fully embodied, shake off the stresses of our other life so that we can show up fully and completely for the patients on that day. The intake process for the Roots to Thrive program is they're referred in to by their primary care provider. We assess suitability for the program and make sure that they can actually show up for the program, that they have the capacity, that they have enough regulation to be able to show up. They go through a number of assessments: depression, anxiety, PTSD, resiliency, and we're adding in future cohorts more around sleep, nightmares, chronic pain, etc. They then go through a psychiatric intake if needed to, again, ensure that they'll be able to show up through the whole program. And then the final step is medical to make sure that there's no contraindications for them to be using ketamine in the program. The measurements I mentioned earlier are here. And we're adding more as we go, always keeping in mind that we don't want to over measure our patients, because that in itself can be a trauma for many of our patients with PTSD. Throughout the program, quality improvement is incredibly important. We have anonymous feedback solicited at, there's a link that all the participants get that they can give feedback at all the times, and anything that we can implement, we put in as fast as possible. So the program, we hope, is always better each week, and certainly is much better with the subsequent cohort that starts. We actually have a cohort now that's just in week 2. The team itself, the whole team meets on average twice a week, and also in some small groups. There's some facilitator learning groups, so to help the facilitators problem solve and learn from each other. And then the whole team meets again, just to learn from each other. We have learning, we have quality improvement, and we all, like I said, the team really works on embodying all the practices, and we lean into tension and challenges. In fact, we encourage people to bring the challenges, but also the solutions. And we feel that when you can navigate tension in a healthy way with your colleagues, and that's where growth happens. So as I mentioned, the team is growing. The team started quite small, around 8. We're over 45 now. The way people join our program is we have them go through the program first as a participant. The best thing that people can do is feel what the program is about, feel what it is like, feel what is the structure, the container that we are setting up, and really feel it for themselves. Because once you feel it, then you know what you're creating and why you're creating it. And then, interestingly enough, we have a lot of MDs, psychiatrists, nurses, et cetera, that go through our program, first responders. And we always ask them at the end, do you feel that you needed to go through the program to join the team? And at the beginning, they don't think so, but at the end of the 12 weeks, unequivocally, everyone says, yes, you absolutely will have to go through the program to really understand. And it's an opportunity for personal growth, and we all need that. Healthcare providers right now are as you know, under incredible stress. It's hard in these times to take good care of yourself, and it's nice to be in a program that takes care of you for a change. After you finish the program, you can be mentored onto the team. You can join the team, and we're mentoring right now satellite teams that are developing in their own areas around the province, and they stay tethered to us as much as they want for mentoring and learning. So we use ketamine as a tool and not as the main show here. We say, come for the ketamine and stay for the community, and that is really true. So we really, we work on the set and setting all the way through. The integration starts right from the very beginning. And the ceremonial aspect is very important. We have the 3 group sessions, and we use the psychedelic dosing intramuscular. Earlier on the program, we started with lozenges, but we found that people having to hold that mouthful of goo, differential absorption rates, it made it so much easier and so much more predictable to just use the IM range, or the IM ketamine in the 1 to 1.5 milligram per kilo range. And each person goes with the dose that is most, that feels best to them. We have a medication consult with them prior to their sessions. Integration is from the first day of the program, and within 36 hours of their ketamine session, there are up to 3, sometimes 4 opportunities for integration sessions with the group. And as you can imagine, there's a high level of anxiety right now, and a high level of anxiety in these patients. And part of the accelerated healing from the program comes from these groups. So they actually get randomly assigned to the integration groups, and they're integrating often with people they don't know. And that causes some anxiety at the beginning. Again, though, 100% the feedback from the participants is, it caused me anxiety, but going into a group where I could integrate and others could compassionately witness me and hear my story and still like me and still feel for me and express compassion was incredibly healing. So the whole program is designed to help start to widen the windows of tolerance that these patients come in with. And so then being held not only in a team, but also in their small groups, but then again from mixed small groups, it keeps expanding their windows of tolerance, and we start to see, the anxiety dropping. We start to see their sociability improving. They start randomly giving us feedback about how much more they're starting to do, how much more integrated they're getting into their own communities. And so sometimes you have these little accidental findings in the program, and this is one we're definitely going to keep. Within those groups, we practice what's considered unconditional positive regard. You've heard that before, and that is something that is one of the mainstays of the program. Just show up, you're perfect as you are, and you will be seen. At the end of the 12 weeks, we don't just drop them. It's not just the end of the program. They can move into the Alumni Program. Many are mentored onto the team. And then the alumni group meets about every 2 weeks, and they have optional ketamine sessions. So back to the results. So we crunched the data on our stuff. We published in Frontiers of Psychiatry, and the results remain the same. We keep seeing this no matter what. We'll keep publishing on it to add to the literature, and we do have some clinical trials planned. So the results we're seeing also decreased substance use quite remarkably. There is a buddy system within the program, and actually they end up actually forming quite good friendships. A lot of groups actually, we get feedback from them. They've gone on vacation, they're going on retreats. I mean, their lives are changed. They're no longer dealing with their PTSD or their depression. They have reintegrated back into their lives and communities. So our access model is known as turned away. It's a hybrid system. The healthcare pays part of it, pays the MDs. The rest is private pay. Some disability insurance, workers' compensation pays for it. The nurses union has embraced this fully, completely, because we are getting the nurses back to work. Right now in Canada, the nurses are exiting the healthcare system incredibly, and our program is getting them back to work. So the nurses union has said that they will continue to keep putting nurses through our program. I think we have 35 in our current program right now. And then we take donations from foundations and charities to sponsor spots. Again, we do everything we can to never turn anyone away from the program. And the other reason why we are publishing, and we're really focused on publishing as much as we can, is to show that the evidence that this saves money. The program costs about $6,000. And this cost savings at a minimum is probably $30,000 to the healthcare system per person that goes through our program. But we have to obviously show that. The other result is we also have a large, healthy, happy, evolving team. Our team is happy. Our MDs, our nurses, we all work together so well. The whole team works together well. I've never been happier as an MD, and I've never felt as challenged as an MD for my skills to constantly be evolving and getting better, and getting to learn from such an interdisciplinary team is just absolutely an honor to do this work, and to really show up as a team. This is why I went into medicine. This is why I went into healthcare, is to help people and to work with people that are wonderful. And that's what happens in this program. So our next steps is we're about to publish our safety data on 450 sessions. There's not very much our safety data on intramuscular ketamine, tons on IV ketamine, as you all know. But we want to get that safety data out, and really it is it is so little. It is some nausea, some vomiting, a few headaches, a few extended altered states, but really that's it, and the transient bump in blood pressure. So I think this will really help community physicians that are doing ketamine-assisted therapy, this safety data. We're also publishing on another arm of our program that provides psilocybin-assisted therapy in the same model. It's a slightly shorter model, an 8-week model, with psilocybin-assisted therapy for those who have qualified in Canada for their Section 56 exemptions for psilocybin mushrooms. And we have a second cohort that will be going through shortly on that, and we'll publish on those results. We're adding in more specialists. As you know, people are not just their psychiatric disorders, they're whole humans. And so we recognize that many of our other specialties also completely are interwoven with the PTSD and the depression and anxiety. So the sleep disorders, substance use disorders, chronic pain. And so we're adding those measurements in, and we'll be publishing on those measurements as well to see if our program has the same kind of results or the results that we're seeing, at least in anecdotal evidence from our patients. The program will also be affiliated with a program that is launching this September on Vancouver Island, the Postgraduate Certificate in Psychedelic Assisted Therapy at Vancouver Island University. Our program will be the practicum site, or one of the practicum sites for the program. So people that participate in this certificate, professionals that go through the postgraduate certificate, can come through the program for their practicum. And we're going to continue to publish on our outcomes. We're community-based. And we're pooling our resources and our time to add this off the side of our desk many times removed to pool the resources to publish on this, and so that we can get the data out there for community-based therapy. Here's our team. It's a large team and wonderful, loving, heart-open human beings that are showing up fully, completely. Many of them were leaving medicine until they came through our program, and then many of them have joined our program, and we are honored that they have seen us fit and willing to join. And so that is the Roots to Thrive program with ketamine-assisted therapy embedded in it, and our results and the structure. And I am.
Well, that's fantastic.
Thank you very much. Questions?
Thank you very much indeed, Pamela. That's really inspiring and a great story of what you've achieved. So thank you for telling us about it. We've just got 3 questions so far in the Q&A. Do keep them coming. So we'll just go through those. They're fairly simple questions, straightforward questions at the moment. But we'll go through those and then delve into this in a little more detail. So what's the time lag between the ketamine administration and the team treatment sessions?
I don't know that I understand that question.
I think so. You've got I think you explained it at the beginning, actually, a bit with the. So there's a question about the structure of the program. So you've got the 3 ketamine sessions, and I think the question is really about how those relate to the integration sessions.
Okay. Well, here's how. So the participants are meeting online for the first 4 weeks, and then the weekend. The first 4 weeks is just online.
Right.
So they have 2-hour once a week sessions online. They have their ketamine preparation session is in there. There's a whole hour dedicated to all their Q&A and answering all their questions. And then they have an additional one-on-one session to ask any questions that they have. And then they all show up in their small groups at our therapy center on their day of therapy. And then they all have their ketamine together. So they have their dosing together. Once they're all in the room, it looks very much like, mats on the floor, ceremonially set up. They come in, and then once they're all in the room, it begins a ceremony. There's a meditation, there's grounding, breath work. The participants share in a circle what their intentions are, what the agreements are, what they want from the team about everything. We have the eye shades for them. We have synchronized music. We have special, a playlist that is made for each cohort based on them. So each session has a different playlist for them. And then they tell the team, I want 0 touch, or I want somebody to hold my hands. Or if I am asking for help, I want it to be a female therapist, or I want it to be a male therapist, or I don't care, and remember, the team is in there. Their facilitators are in there, and then there's a number of our skilled team members on there. And so they have their journey together. They come out of the medicine at some, as you know, the metabolizing it at somewhere between 40 to 90 minutes approximately. And then when they're ready, they again share in circle about what their experiences and what they learned, and they're compassionately witnessing each other and showing up again with unconditional positive regard. And so the group session happens there. And then after that, they go home about the 4.5 hour mark with their driver, their family member. And then within 36 hours, there's a number of sessions where they can jump into. for integration. And then that is repeated on the following 1 week later, and it's then repeated 2 weeks after that. And then there's 4 more weeks in the program. So I don't know if that really answers that person's question, but I'm happy to, if there's another question with it.
That's really helpful, thank you. So why did you decide to go with IM rather than IV?
Yeah, great question. Well, like I said, we started with lozenges, which were, if anyone's ever held a mouthful of ketamine lozenge for 20 minutes, you'll know how fun that is. So we stopped that, and we went with IM because we know what the bioavailability of it is approximately, and it's close enough for us. And we didn't want to have to go down the route of the monitoring that would be required. The cardiac monitoring. We knew the safety data around ketamine. I've been working with ketamine right since I was a medical student, so I felt really, really comfortable with it. And I did a lot of training and worked with some really good mentors. And so we just wanted to go, we thought that that's the least encumbering. The team, everybody gets injected about almost exactly the same time, and they flow through the music at the same time, and we see some pretty predictable results. And we get them into the I can see one of the other questions, like it seems pretty low. It's actually not. They dissociate, they get into the psychedelic realm. The other thing we've done to enhance the program now is because, as you know, some people have really high anxiety. We really do tailor the dosing to what their needs are. So if their anxiety is really high, I can give them a very low dose, like say 40, and say, you know what, I'm going to come and ask you at 5 or 10 minutes if you want some more. And then they're relaxed and they can feel the ketamine, and then they're all in. Then they're like, but we've already predetermined it before they've had the ketamine. So I'm saying at the, somewhere between the 5 to 15 minute mark or 20-minute mark, depending on the goal of the person, the size of the person, then we predetermine, say, okay, so you can ask for up to 40 more, or depending on their weight-based dose. And so we do try to tailor it so that people can relax and get into and not be holding on to the side of the pool going, I'm not going in, we want to facilitate that. And then there's a few other dosing things that we do as some top-ups through. So people that are fast metabolizers, like, especially after the first one, if they're like, I was out of that at 40 minutes, I would have really liked to have stayed in longer. Those people will give a bump at 20 minutes, so they stay in. And so we play around with those doses. But the IM, because of the bioavailability, and we just didn't want beeping machines, machines that go bing in the room. We didn't have to worry about those sort of things. Little Monty Python reference there. That was it. It's easy. It's easy, clean, and then we can relax into letting the patients have their session.
So obviously, because everybody's in the same room together, they're all hearing the same music.
Yeah. So what we did is we fortunately with COVID, all this, all the silent discos kind of got shut down. So we got their headphones, and so we have a synchronized playlist for them, so we have the music playing in the room, so they don't have to wear the headphones. But we have found the headphones have been so helpful, because if the person over on the other side of the room is screaming, they can't hear them, and we know that whatever that process they're going through is really important. The person who's screaming or laughing, often it's laughing. And actually what we do find in the room, which is really interesting, even though they're all wearing headphones, if one person starts to laugh, almost inevitably the whole room starts laughing, even though they can't hear each other. It's actually really pretty magical. But yeah, they wear the headphones, so they can adjust their volume, so that if they just don't want to hear anybody at all, they can really be deep in the music.
Okay. Thank you. Here's a question. If possible, can you provide the benefits from your beautiful holistic approach versus ketamine? Do you have a program without ketamine earlier with which you could compare? Or are there any participants who cannot tolerate ketamine but undergo the journey together that you can comment on?
No, thank you for asking. I actually didn't tell this part of the program. We have at the same time running side by side just the Roots to Thrive program without ketamine. So they actually come through the whole program and get all the same learning, all the same teaching, all the same small group. They just don't get the ketamine. The numbers in that group tend to have less acuity. Like there's not as much PTSD in that group. The depression scores are slightly lower, but they're definitely people that are probably like early on in burnout, or maybe they've just had a few layers of trauma coming on, and they do really well, really well. And we'll probably be publishing on that. We're crunching the data on them right now, and it is really actually inspiring too. And maybe we might even be scratching our head going, do we even need the ketamine? Maybe we don't need the ketamine. Maybe we just need the group therapy like this, but we'll see. But again, like I said, the acuity in the ketamine, there's a lot more PTSD there. There's a lot, the scores are higher. And yeah, so side by side, there's two programs is what I'm saying. So without the ketamine. And the other thing we find is that people that go through the program, the Roots to Thrive program without the ketamine, they still go into the alumni program. And very often, probably about 40% of the people that went through the Roots to Thrive program and go into the other one are then asking, like, I think I'd like to do a ketamine session. And so what we have done is we've evolved to create a small mini Roots to Thrive for them, because they've already been through the program. They've already brought the resiliency up. They're functioning at a much higher level than they entered. And then we're saying, okay, so we facilitate a small alumni group for that group, and they have the full integration, et cetera, et cetera. So it's an evolving program, as you can see, like, and this speaks to the quality improvement, really listening to the participants and what they want. They're telling us how to evolve the program. They're telling us what they need, and we're listening, and it's working fabulously. It's really, it's a really big part of research here in British Columbia is patient-oriented research, really making sure the patient's voice is heard, that we're studying and doing what they want, not what we want to do.
And Renata Alfonso is obviously sold on this. Dr. Pamela, I absolutely love the concept of this project, from the use of ceremony and elders to the integration, group sessions and buddy system. This is a very similar concept to what I would like to develop in my home country of South Africa, where a lot of healing is needed. Expect an email from me soon. Thank you. So that's nice.
Yeah, the ceremonial, it's really nice in a way. I feel like the last few hundred years, I mean, I haven't been alive that long, don't get me wrong, but I feel like, we all came from ceremony. We come from community. We have all these ceremonies, birthdays, weddings, and then we try to like surgically remove them from medicine. And that's the fun part of life. And we're putting that ceremony back into medicine in a very holistic, science-based way. Like there's harmony there. And to work with Indigenous elders that really like come in and just land it. Like they land the psychodynamic theory better than I could ever do in real language that matters. And you bring that in together and you remove the hierarchy and you all lean in to do what's best. You nourish yourself as a healthcare provider. I feel great. I would do this program for free. If they said, Pam, we can't pay you anymore, I'd still show up, because it's why I went into medicine. And I'm happy. And I know I'm making a difference. And I know I'm personally becoming a better person while I do it. And to be able to show up and help my patients that and go, yeah, I've been there. I know what you're talking about. Like, I hear you. And they know we're not just blowing fluff at them. So absolutely. And so I hope that even if nothing else, like a lot of the MDs that go through our program, we hear back from them right away. I'm already changing how I'm showing up for my patients. I'm changing how I'm showing up for my family. And that's great. I don't want anyone to burn out. I want us to be healthy and happy and whole human beings.
Great, thanks. So question here, do you find that most patients have a meaningful experience during ketamine, or do some just feel zoned out? So what's the sort of
absolutely. Oh, absolutely. The meaning, what is really interesting is, so they've already been meeting together for 8 hours by the time they have their first session, online. And it is actually amazing how strong the bonds have already formed. Like when they show up on the day, they've never seen themselves in person. They are hugging and saying, oh my gosh, like it is really amazing. Like I would not believe it if I wasn't seeing it. If you were listening, if I was listening to me, I'd go, yeah, whatever. But I'm very skeptical, but I see it. They're already connecting. They're already noticing things. And then in the ketamine, they definitely, you know, everybody gets into a psychedelic zone. Like with that, that's my goal, is to get them in there so they can get into the transformative dosing ranges that they can, you know, they can get the transformation they've come for. I mean, if you're going to commit to a 12-week program, you're not happy with life. You're not happy with where you are in life. And we want to make sure that people can get to their goals. And that's part of our intake. Like, who do you hope to be at the end of the program? How will you know that this program was successful for you? And so we really help facilitate that. And they do get that. They go in deep. I mean, people have, you know, transformed through like horrific traumas, you know, some that we didn't even like fully appreciate until they were in the session, you know, sexual assaults, incest, you know, like we have first responders, firefighters, like multiple, you know, layers of trauma from their job. And they're able to move through it and cry and laugh and be heard by not only the team, but also by the other people in their program. And I think that's why the healing is so elevated, is, you know, it's not transactional in a way. Like, I'm paid to be there, but the other 7 participants aren't, and they're hearing them and they're listening and they're leaning in and going, oh my God, I feel that. Like, wow, it's amazing what you've accomplished considering what you had to go through as a child. You know, they're heard, they're reparented, they're reattaching, they're feeling hurt. Like, it's magical. So yeah, they're not zoned out. Absolutely not. No.
Sort of related to what you've just been saying, and perhaps we can cover this and then move over to the other, to the second part. Have you frequently encountered abreactions, and how is that managed? And then do you have concerns about ketamine naive patients having their first experience in a group rather than one-to-one?
We don't, like, the reactions. First off, the team is really skilled, right? That was the first and foremost. Like, we had to be solid as a team, and nobody on the team was psychedelically naive. So everybody was aware of non-ordinary states, either through holotropic breathwork or their previous psychedelic experience, or, you know, ayahuasca in Peru or something. And so that really matters. Like, you have to have a really good grounded team, and you can handle anything. So yeah, some people have big reactions, and then the team is calm, relaxed, and there and present to help them through that process. And they do really, really well. It's about the team. If you're not grounded, if you're anxious or scared, you should not be doing this therapy. You really need to feel comfortable and confident, and know that the team is skilled. And so if the person's having a really hard time, you can hold that trauma, you can hold that person and move them through it, and then help them integrate it. And so that's why I love the group structure, because if I'm having an off day, I've got a team around me that will hold that container of healing. Now, when I used to do one-on-one and dyad work, if one of us were off, like, that could have implications for the patient. Whereas when you have a team in that room, you know, if somebody is getting dysregulated on the team, we just say, you know, go for a walk, come back later. We have a big enough team here to handle it. So we don't have any issues at all. Like I said, the safety data is going to show the expected blood pressure bumps. We have some nausea, we have some vomiting, we have some headaches, and some people that are just very, very slow metabolizers. But we've had nothing, you know. We make sure there's space. We have extra cushions and stuff in the room. So if somebody we've had people get up and dance. I don't know how they've gotten up. I don't know how their legs worked on that much ketamine, but they do get up and dance. We had some people, like, you know, being obviously wanting to punch, and we just have big couch cushions. We can just hold them there and they can hit them. And then it processes it. So we've never had any. So it's preparation for everything. Just ready.
I'm actually going to go through these questions because I think that there are some interesting points. So have you observed any differences between major depression and PTSD in the outcomes and the process? Anything of that sort?
we're getting great outcomes with PTSD, and we're trying to make the argument for the nurses, doctors, and first responders that we see them earlier, not right after, but within a couple months or so that they're not stacking a whole bunch of traumas. We're getting really good results, and like we do have some people that I think, like as we all know, that they're going to need top-ups for longer. They've been on this journey for a long time, like a lot of treatment-resistant depression and MDD. But our psychiatry team, takes a very holistic approach, and we keep offering tools. Many people will stay on their medications. We don't do anything radical. We move very slowly with them, and just support.
Will the top-ups be? Sorry to interrupt, but will the top-ups be within the context of the same will they be sort of recycled into the next cohort, or will they have individual ketamine top-ups, or how would that work?
Yeah, we may down the road do some one-on-ones. We're seeing that there's maybe like very few, maybe 1 or 2 people per cohort that might do better just one-on-one. But what I was saying about the alumni program, everyone goes into the alumni program, and then when they feel that they have integrated everything that they have learned and they're ready to take it to the next level, then they apply, and then they go through another screening, a shorter screening, because we already know them, and then we facilitate alumni groups, so they come together as a new group again, expanding window of tolerance again, and they prepare as a group for their session. So they have to meet at least 2 weeks prior, and then they have their ketamine as a group, and then they also integrate together. So little mini pods in the alumni. And some people, we have people that went through our very first cohort that are now coming back and saying, you know what, I'm doing fantastic, but I still have this little something I want to deal with. And and so it's kind of stuff like that. They're wanting it. We kind of think of it like a gaming, like in a video game. Like they're already at level 15, but they just want to take to level 17. They're doing well, and so that's how we're seeing it. They really are. People are doing their work. They want it. We're not seeing people like banging on the door saying, "I want more ketamine." They're like, "I'm ready now. I have done the work that I learned from my previous sessions. I'm using my tools. And now I'm ready to take it to the next level." We are not seeing abuse. We are not seeing frequent flyers. We're seeing really thoughtful people that have taken their life to the next level.
Just out of interest, how long has it been since the end of your first cohort? How long ago was the end of your first cohort?
Just over 2 years now.
Okay, thanks. What's the client facilitator ratio for the group sessions?
Yeah, in the small groups, there's 2 facilitators for 7 or 8 participants. Those facilitators are in the room, they regulate their room, and they run the ceremony. And then we have a team that floats. So extra facilitators that may just sit. We're always mentoring people. And so those people that are mentored, the participants already know them. They've already had a chance to meet them. And those people may just sit and observe. We feel that if people are going to do ketamine-assisted therapy, it's really good for them to see a lot of it, and if you can sit in a group and in a day see, maybe 32 different, like maybe 4 groups of 8 go through it, that's a lot. You get to see a lot of stuff, and you get to see the whole range of what ketamine does with people and how all people work. And so those people are around if needed. A lot of the times we just need people to help people go to the bathroom. It's really about that. As they start to come out, we need 2 people to take each person to the washroom. But what we, to actually answer the question that was asked, how many people are in the room? There's always 2 facilitators, and then there's at least 4 other people that are nearby or ready to help if needed. And like I said, it's more around taking people to the bathroom or, stuff like that.
We've got another sort of practical question. How do you choose the optimal ketamine dose for each participant during the pre-visit?
Witchcraft. Sorry. No, actually, there was another question too I'll answer about the naiveness. So we want to get them into the psychedelic dose, but it depends where they're at. They've come for transformation in the program. They want to take their life to a better level. They want to resolve what they've come into the program for. And it's a conversation. So they meet with myself or one of the other physicians a couple times just to talk about what their goals are and what they want. Most people really, honestly, they're like, I'm all in. Give me what you can. And so what I do is we'll dose them up at the higher end of the 1.5, and then see, like, the nice thing is we have 3 sessions, so then we can play with it. So we don't have to worry. I'll say, you got 2 more sessions, don't worry. And so they'll get into the zone, and then we have another discussion to figure out where to go. But and they do know if they're worried, if, like, some people are like, what if I don't go in? Then we always make sure the top up is offered to them. So it's not, it's very rare that we have somebody. We do have some people that are very rigid. Like if they have a very, very rigid personality, then we have long conversations with them to figure out if they're actually going to allow themselves to get into medicine. But so it's a fluid conversation built a little bit on the formula by weight, but also a little bit intuitive and also built on the patient's goals.
Okay, thanks. Are there any training courses you'd
recommend? I think there's a lot of programs that are opening up. We
recommend to medical professionals who are planning.
Oh, is that me or?
Sorry, no. So there was a glitch there. So I'll ask the question again. Are there any training courses you'd recommend to medical professionals who are planning to work psychotherapeutically with patients in ketamine?
Well, I think first and foremost, we all believe you really want to be first really good at what you do, like really good on some sort of therapeutic level. That's first and foremost. And then you can add any psychedelic, I think, on top of it once you really understand the medicine, the indications and the contraindications as the science develops. In North America, where I am, Phil Wolfson does some stuff, Fluence does some stuff, Polaris does some stuff. I think, a lot of those are 4-day things. And, I think it takes a lot more than that to get to the place where you want to be using it. So if you can ever connect with somebody to mentor or work with a team, I highly recommend that. Again, I feel like I was lucky that I got to see hundreds of ketamine sessions and really see the shit hit the fan on some of them and go, oh, okay, well, that's worst case scenario. Now I've seen it. You can relax. And also at my Emerge background helped with that. You really see it go into my South African friend that asked the question earlier. I worked in Matuba for 2 months. So I used a lot of ketamine there for traumas and car accidents. But I think you're going to see more and more programs depending where you are. And I couldn't really speak to the quality of all of them, but I think most of them are very well-meaning. And get into a professional accountability group right away. Get connected with other physicians or practitioners in the area, other therapists, nurse practitioners, whoever's doing ketamine, and do ongoing training and do sessions together and learning together. I always think that's one of the things we don't do enough is learn from our failures with each other in a wonderful community where people really want to do something meaningful, and people that do this kind of work, I think, are more open-hearted about sharing about what the challenges and the failures are.
Thanks. And then perhaps I realise that we're getting towards the end of a little bit towards the end of the time, so I think we'll just stick with this format for now. But Kate, one of the questions was about what are your long-term ambitions for this, and how do you see this sort of? I mean, you do what you do, and you do it very well, and you do it for healthcare professionals. But how do you see this working at scale?
Well, that's what I think our grand vision. We created a nonprofit for it because we had to have a structure that would not turn anyone away no matter what. And we thought sometimes you just have to be a ninja in this world and just go where the doors are open. And so our hope was that what we could do is create, with constant quality improvement, and this is actually what we are doing. So is creating a structure that people can learn, that people can come through the program or go through a program, feel the program, understand the program, and then take it to where they work and adjust it for the culture of where they work. Because it's in, we have a different culture in British Columbia. We're very integrated with First Nations, and it feels very natural. That may not be what it feels like where you are, but creating a very good interdisciplinary team. And we see it as satellites, like the Roots to Thrive Resiliency is always in quality improvement. And so, we have groups from other places that are not near our program that where their participants sit in on our session and then are facilitated with their facilitators that are meeting with our facilitators and know exactly what the game plan is. And then they're hosting their own ketamine-assisted therapy sessions in their location. So those patients aren't having to travel. So we see it as a satellite type thing. We built the whole program and the guidelines as a psychedelic assisted program. And so we already have added psilocybin with the Section 56 exemptions in Canada. We will add MDMA next year when it becomes a medicine again in Canada, and any other therapies. And so we're very science-based. We will adjust as the science improves, what medicine, at what dose for what population. And we hope to have a big tent kind of approach to it, that the patients are going to get the best therapy for them, for what they need. And we're really pushing for billing, that it's covered. And we have universal healthcare in Canada, and only a portion of our program is covered, and it should be completely covered. It's a massive cost savings. If they crunch the numbers, we'd be saving people like so much money. We need to make that economic argument for them, obviously. But that's our hope, that your patient comes in the door and you can go, oh, psilocybin for you, or oh, couples therapy MDMA, or PTSD MDMA, best medicine for the best patients with healthy, happy teams.
So just to pursue the politics of it, to finish off on that level, and the billing and insurance and all this. I mean, you cost about $6,000 per patient, and at the moment, you've got people who are paying for other people who are paying for slots, and you're hoping that eventually that'll be the taxpayer who pays for those slots. Are you actually collecting data on people's on the functional disability that they have and on their resource utilization? Because at the end of the day, that's what counts.
Yeah,
that's what counts for some people.
Exactly. I mean, if you like people, the program's great, and if you don't like people, the money savings great. So it's a win-win either way. So we looked at the MAPS data on the MDMA for PTSD, and they did a really good cost analysis. And we looked at that, and their program's a little bit more expensive. I think they think their break even is about 12,000 American for the MDMA, which is 3 sessions and a little bit more intensive because it's dyad and not group. And so based on those numbers, I mean, the quality of life stuff and the cost savings per person is well quantified in their study. And I think that is actually on our research list with our PhD students, is to actually do that, crunch the money and go, okay, this person has PTSD, they're a firefighter, this is the cost to the employer to have them off on disability. And then this is also quality of life. This is the cost to their family. This is the cost of the society, and do those numbers. And I mean, I think off the back of the napkin kind of calculations I've done, it's at a minimum, our program saves about $30,000 at the absolute minimum. And that's what I did by cutting it in half to be extra careful. So I think it's at least $60,000 per patient that comes through our program, savings to the employer, to society, to disability, et cetera, et cetera. So we're really focusing on workers' compensation too, making the argument to them, saying, pay for 10 people. And if we prove it, then pay for 20. And, before you know it, like, you're going to be saving money all over the place. But we're community-based researchers, right? So we can only do so much, and we'd rather be treating patients than crunching numbers. But yeah, and I saw the question about COVID. One thing we did is we got industrial HEPA filters. We got the highest quality HEPA filters. We got them early. And what we do is we have them in the rooms. So we follow COVID precautions, and with the HEPA filters turn over the air in our therapy rooms every 3 to 6 seconds. So, and we also use the MIT particle science physicists have a resource that you can do. You can put in all the calculations of your room size. Do you have windows? Are the windows open? How are people talking? Are they whispering, et cetera, et cetera? And you can also do the particle science calculations. And we did that. And we could have something like 50 people in the room based on what we were doing. And we only have like 10, 14 in the room at the most. So yeah, if you can get really high quality HEPA filters, if you can have windows cracked, we wear masks. We do try to require vaccinations, but we don't want to be political. So we're like doing that dance a bit. Yeah, and we've had 0 transmissions.
Now, have I asked all the questions that people wanted to answer? There's one here at the bottom. Do you provide any anti-nausea medication previous to the ketamine sessions?
No, and some of my ER docs want to give ondansetron to everyone. No, we have it. We have a lot of options. We have acupuncture, the wristbands that people wear on boats. We brought those have been helpful. We have ginger, we have peppermint, we have aromatherapy, and we have ondansetron, and we have Gravol. You probably have a different name for it in UK. And so we have a full slot. We also found, interestingly, salt is really great. Like a salt after. So we have saltine crackers in the room after, and that really settles people a lot. And so we're also relaxing the no eating before. I think a lot of people get nauseous because they're just hungry. And so we allow them to nibble. Say, you can nibble all the way up, just don't eat a full meal. And that has really lowered it. And then for those that we know are going to have nausea, they get ondansetron ahead of time for our 8 milligrams.
Yeah, and I think this is going to be the final question actually, but do you collaborate with practitioners of East Asian medicine, acupuncture and herbs as well?
We haven't brought much in other than like some basic botanicals like ginger and peppermint, and then the acupuncture things. But down the road, like we were thinking about, the whole human being and really wanting to bring in more of the senses. And so, looking at maybe some aromatherapy, hypothetically, who knows? I mean, especially when you think of PTSD, like how many things are embedded. There's the sound, there's the smell, there's the sight, there's the somatic. And we're going, well, if all those things affect us in a trauma way, is there an interesting way that we could use more modalities to move people even faster? So we're curious, we're really curious. We don't know the answers, but if we can add something to the program safely and it accelerates people's healing, then we will try it and we will study it and we will punt it back out to the world and say, this is what we found. But we don't have the answers.